Thank you and welcome everybody to the webinar. We are pleased and humbled to partner with the Yale School of Public Health to share their wonderful work in regards to COVID-19 testing. Yale, spearheaded by Dr. Wyllie, who will be presenting, has developed the SalivaDirect protocol, which is a simplified and really flexible platform to enhance COVID-19 testing capacity. So my name is Mono Patel. For those of you who don't know, I will be the host and the moderator, and I'm the global product manager for the PCR, qPCR, and cDNA synthesis portfolio at QuantiBio. Before we begin, we really wanted to just give a quick overview for those that are new or unfamiliar with QuantiBio and the work that we've done, especially in the last 12 months, particularly with COVID-19. QuantiBio has been extremely fortunate and grateful to aid heavily in the fight of the COVID-19 pandemic, starting with two CDC EUA-approved products in April of 2020, our QScript XLT Tough Mix and the Ultraplex One-Step Tough Mix. And as the summer went on last year, the CDC was just continuing to update their protocol, and the Ultraplex One-Step Tough Mix was actually validated for heat lysis, which is a viable alternative to RNA extraction, saving on time, costs, and particularly resources. And it was also validated for the ability to multiplex up to 5 targets and really just be used for a variety of not just COVID-19 related issues, but influenza and respiratory diseases. Our R&D team wanted to continue to improve on existing technologies and really develop new technologies as fast as we could. So with that, we were able to develop a third master mix, which was the QScript One-Step Virus Tough Mix. And this was a 2x master mix, really ideal for low input quantities of RNA. So we just wanted to continue to develop a breadth of products, especially given the situation that we're currently going through. And in collaboration with amazing partners and collaborators, we've been able to work with over 100 testing companies in over 37 countries to really aid and support worldwide COVID testing. And from December of 2020, and this number has most likely increased as we're approaching May, we've been able to help manufacture in excess of 56 million COVID-19 tests. So really working as hard as we can to do our part to support the current pandemic. And here's a quick breakdown of the various products that we have to assist in COVID-19 testing, but we really want to focus on the Ultraplex One-Step Tough Mix. And the reason is because this product has been considered for evaluation and validation in the Yale SalivaDirect protocol as a PCR master mix that can be used and will partly be discussed today. Before I have the pleasure of bringing up Dr. Wyllie, there are a few disclaimers that all QuantiBio products are research use only for molecular biology applications and really aren't intended for the diagnosis, prevention, or treatment of a disease. And there were no financial interests between QuantiBio and the Yale School of Public Health, particularly in regards to data generation or presentation of findings. We really wanted Dr. Wyllie to have the space to share her story, and that will include the validation of a variety of PCR master mixes even prior to the Ultraplex One-Step Tough Mix. So we are looking forward to having Dr. Wyllie share her story. She has a PhD background in epidemiology, initially focused on pneumonia, and has obviously shifted towards COVID-19 and has developed this SalivaDirect protocol to address COVID-19 testing bottlenecks. So I do not want to take any more time away from her. Without further ado, please help me welcome Dr. Wyllie.
Thank you for the kind introduction. So indeed, I'm happy to be here today. Thank you to QuantiBio for hosting me. I would like to present on SalivaDirect. This is a simplified and flexible platform to enhance SARS-CoV-2 testing capacity. So where did this all start? This started actually over a year ago now. We set up a biorepository at the Yale School of Public Health to help study SARS-CoV-2 and COVID-19 disease progression. For this, we were obtaining samples from COVID-19 inpatients, a whole array of samples: nasopharyngeal swabs, oropharyngeal swabs, saliva, blood, urine, rectal swabs, as well as trying to get nasopharyngeal swabs and saliva samples also from outpatients and healthcare workers. Unfortunately, I think like so many other people in this whole pandemic response, it was, putting out little fires every single day. And so many of these very early on revolved around the nasopharyngeal swab. They are difficult to obtain. They are uncomfortable. This leads to the risk to the healthcare workers in terms of if a patient is to sneeze or cough on the healthcare worker collecting that swab. They also have testing aversion, individuals, especially sick individuals. We were missing out on research samples because, of course, we were taking a clinical diagnostic nasopharyngeal swabs, but patients weren't wanting to give a second swab for research because of how uncomfortable they were. We also all know about the supply chain pressures that we found when, the gold standard just defaulted to the nasopharyngeal swab based on what we've known previously. And we saw that collapse of supply chain and, everyone was there scrambling, trying to find alternative ones. We were looking at 3D printing swabs. We were making our own viral transport media, and this is, I think, similar to so many other, institutions all around the country. All samples that we were receiving, we were processing by RNA extraction. This also had its own limitations, being it is the most expensive step of the process, labor intensive, and there were also shortages in the supply chain around RNA extraction. We were testing all samples in RT-qPCR for the CDC's N1, N2, and RP primer probe regions, so the N1 and N2 of SARS-CoV-2, and the RP as the sample quality control, the human control. Again, running 3 PCRs per reaction was expensive, labor intensive, and we also we led to a few inconclusive results with the N1 and N2 discrepancies that we were seeing. As I said, though, we were collecting saliva samples, and we actually saw quite promising results from saliva samples early on. So as all of these COVID-19 inpatient samples were arriving at the lab, as I said, they were all being tested immediately for SARS-CoV-2 RNA before we were biobanking them. And knowing the problems that we had with the nasopharyngeal swabs, but also just looking at all of the SARS-CoV-2 RNA results coming back per patient, we suddenly realized that the saliva samples were indeed looking promising. We didn't want to get too excited too early, so we decided to build up a sample set. And this is our paper, a picture from our paper in the New England Journal of Medicine, where we found at least that saliva was often detected in higher amounts. The SARS-CoV-2 RNA could be detected either in higher amounts than in the nasopharyngeal swabs, or even more reliably at times. So this led us to realize that there was potential for saliva to help aid these testing challenges that we were all experiencing. Expensive devices, however, can impede access to testing. So while we were interested in collecting saliva and that this could produce it could be a viable alternative for mass testing needs, this table, I realize, is small, but it lists a lot of the early saliva collection devices that were out there on the market. And, they range from anywhere from $28 down to $18, $10, $7 per device, which if you were thinking, already in April last year, we were thinking about the need that we're going to have mass testing, mass frequent testing to, return to this new normal that we all keep talking about. But if you're wanting to collect frequent samples from saliva, a lot of these higher prices would quickly max out any testing program. And however, there were more affordable solutions available, such as very simple laboratory plastics, such as a urine collection cup or a wide mouth tube, or even something as simple as the Salimetric saliva collection aid, which is a short straw going into a vial just to help saliva collection. The difference between these ones at the bottom versus the ones at the top are the ones at the top have buffers in them, which are marketed for stabilizing RNA, but we were interested in whether these were actually needed or if we could use these very simple devices down the bottom. So we looked into the stability of SARS-CoV-2 RNA in raw saliva. So what you have in this figure is in the very first column, these are the CT values when we targeted the SARS-CoV-2 N1 region when the samples were collected fresh. So these are the results that we had when they arrived in the lab. And then we split that sample up and we froze it at -80. We left it at room temperature for 5 days, or we left it at 30 degrees Celsius for 3 days. Each sample is joined by a dotted line. So these are the results for that same sample in these different conditions. And what we saw was that SARS-CoV-2 RNA seemed remarkably stable after freeze-thaw cycles, room temperature for 5 days, 3 days. And we even extended the room temperature ones out even further. We also go into the other ones further as well. But even looking at room temperature again, the CT values at the time point 0, that's the day when they're collected fresh. And then it's the same, the results for each sample are joined by the dotted line. And you have one that even goes all the way up to 25 days at room temperature. And the detection, again, remarkably stable. That's really highlighting to us that those expensive collection devices were not necessarily required, and we could be collecting saliva in very simple laboratory plastics. So knowing the need for mass testing, I think the last thing that we were just really driven by was the high cost of testing that existed at the start of the pandemic. It's really unfortunate that testing was limited either to those who were just symptomatic or those who could afford it. We knew that testing did not have to be expensive and that there was not a reason for that. So we wanted to do what we could to really make testing more affordable. We wanted to make it more accessible so that more people in the community could reach testing. And especially, again, if you're thinking about frequent testing, every couple of days, every weekly testing, it had to be affordable. And that's what really drove the development of SalivaDirect. So what is SalivaDirect? It is an extraction-free and dual-plex RT-qPCR test. We take a very simple saliva sample, we mix it with proteinase K, you just vortex it vigorously, you heat and activate the proteinase K, so you heat and activate the whole sample, that's inactivate the proteinase K at 95 degrees for 5 minutes, and then you can test that essentially almost directly in RT-qPCR. And we do the dualplex of N1, so SARS-CoV-2 N1, and the human RNA-seq as sample quality control. So overall, this gives it a less invasive, less expensive, and less prone to supply chain issues method. What this method is based on is what I had just introduced, that saliva is stable without preservatives. So again, we have some more validation data which we submitted to the FDA as part of this process, also showing that. We were able to maintain the sensitivity of an RT-qPCR test while removing the RNA extraction. So I think it's important to highlight is that we started developing this almost a year ago. This time last year, we were terrified of false negative results. I didn't want to be missing anything that was 38, 39 CT. We didn't know what that would mean in terms of infectiousness. And if, we know that negative results can change a person's behavior. And if they were going to have a test result that was negative, they believed that they went and saw vulnerable friends or family members that could potentially carry a lot of risk. So while we were removing RNA extraction step, we wanted to make sure that we maintained the level of sensitivity in doing so. Moving over to the dualplex PCR, we did the same. We again wanted to make sure that we could maintain that level of sensitivity when combining our PCR reaction. Importantly, to begin with, we validated this method with multiple vendors. Already in our initial setup, we had multiple proteinase K suppliers, PCR kits, and importantly, PCR instruments. The reason why we did this is that we wanted labs to be able to utilize their existing supply chains. We wanted labs to be able to utilize their existing instrumentation. We didn't want labs to have to go out, find new reagents, find new suppliers, and importantly, buy new instrumentation. We knew that if people had to buy new PCR instruments, those would be costs that would be passed on to the consumers. It would also add to all of these supply chain pressures that we were already seeing. And while recommending a variety of suppliers, we hoped that this would come overcome any potential supply chain issues we might see if one of these reagents was suddenly used for, in another process that was in high demand. And also maybe to help keep some competition between the suppliers, but also meaning that a lot of companies have already got existing customer relations where if you're doing bulk orders, things like that you can get a lot of discounts. So the raw cost of just the reagents is around $1 to $4. Many labs can actually get this down to $1 per sample. That is just the reagent price, of course. We're very well aware that you've got all the other overheads, facilities, staff costs, obviously, taxes, physician ordering. So there are many more costs on top of this, but the fact that we can get the base cost down a lot, we hope that then labs will be able to offer a lower test price in general to their local communities. We also tested the limit of detection for all the different combinations that we tested, and we continue to do so. So this is just a subset of those LOD experiments. Our official LOD is at 12 copies per microliter, so our least sensitive combination is 12 copies per microliter. But when we validate new reagents, new instruments, we frequently hit 3, even 1.5 copies per microliters at times. So depending on the setup you use, there are different sensitivities. Importantly, we completed the FDA reference panel. So the FDA sent out a blinded panel to all EUA holders. We completed that with our least sensitive combination. And using that least sensitive combination, we have the same recorded LOD as the CDC's RNA extraction-based PCR test. So again, just highlighting that we were able to maintain that level of sensitivity while removing that RNA extraction step. We, of course, had to present our clinical validation. So this is taken from our paper where we describe the whole overall validation, but this is also the data that was submitted to the FDA in support of our EUA. So what we had to do is we had to, of course, take the gold standard nasopharyngeal swab and paired saliva samples. These swabs and saliva samples were tested in the TAC-PATH COVID-19 combo kit, and we also had saliva tested by SalivaDirect. And again, we saw a high level of positive agreement and a high level of negative agreement. You will see that for both swabs and for saliva, there were instances where one sample would be positive and one would be negative, or vice versa. Really important to remember about those is that these were samples that were at the lower limit of detection. So, they were in that range of 38, 39 CT for one of the sample types. So it's not as though we didn't see evidence that if you had a really high positive swab, for example, then saliva was negative, or vice versa. It was more around the limit of detection where you just had that disagreement. So this led to our EUA in August last year, where it was described as the most unique EUA that the FDA has issued to date. We received our EUA as a manufacturer. In saying all this, I think what we've shown is that we don't actually manufacture anything. We don't kit anything. We don't produce anything, distribute anything. But our product is our protocol. So the FDA had authorized us to be able to designate other labs to use our instructions for use under our authorization. So for this, we set up our website, which if anyone has any further interest in looking at, you can find our website at SalivaDirect.org. And we have the designation process outlined, and labs are able to request designation and fill in details and find out what they need to provide in order for us to just assess that they've got the assay up and running in their lab well, and sign an agreement with us that they will just abide to the conditions set out in our EUA summary and our IFU. So SalivaDirect is so far offered in 115 labs in 37 states across the country. It is also being used internationally. Outside of this, we have an open source protocol, which outside of the US, other groups are able to use. So the Philippines version of the FDA has approved SalivaDirect for use by the Red Cross in the Philippines. I'm also in frequent contact with people who are setting this up in places such as Bosnia, Spain, Portugal, Brazil. Also currently talking with some individuals in India about what could be done here as well. What's been really inspiring though is just seeing this development of a really collaborative and growing network of labs. We have weekly meetings to give updates to these labs. We have a really active Google group where we can share updates, and labs can reach out to others to just seek advice or recommendations as well. So where we see this and what is really well suited for is for mass testing strategies. We did validate SalivaDirect in asymptomatic individuals. We did have this early partnership with the National Basketball Association where we were able to validate saliva alongside their bubble. So we were receiving every day a lot of saliva samples from NBA players and staff around the country, where we were collecting saliva to test by SalivaDirect, and the players and staff were also having a diagnostic paired anterior naris and oropharyngeal swab. So those two swabs were going into a single vial and being tested at Quest or BioReference. Again, we saw a relatively high positive agreement. We, in the end, I think everyone's heard the success of the National Basketball Association's bubble model, where they had very, very low positives. So we did have very small numbers to go from on the positives, but we received we received over 3,700 negative samples. So from this, we were able to see a very high negative agreement. We had an incredibly low invalid rate, being negative for human RNase P, and an incredibly low false positive rate. The reason for this and how it works well is that going into asymptomatic testing, there's been a lot of questions about what viral load looks like in asymptomatic individuals. Is it are people asymptomatic because it's a very, very, very low viral load? Do you need more sensitive methods to be able to test that? We've actually received CT values from labs who have been doing asymptomatic testing, as well as some of our own asymptomatic tests in-house as well. And we just mapped this next to some of the symptomatic samples that we'd received. And you can see that in blue, that there is a huge variety in viral load, even in asymptomatic individuals, and that it's not this idea that you have just very, very small amounts of virus. So I think important to see is that even if people are asymptomatic, they can have a variety in viral loads that can be detected by these methods. We also like saliva as it's a reliable sample type. You can see what's in your sample. If you give a sample, you can see that it's there. You can see if you've got enough volume or not. You can see if there's anything potentially, any contaminants such as food or toothpaste or something. And this really is reflected when we test for human RNase P. So what this graph shows on the left is when we were testing for human RNase P in nasopharyngeal swabs collected from healthcare workers versus saliva collected from healthcare workers. And we found a lot more variety in the nasopharyngeal swabs that we were receiving. And compared to the saliva, where it was a lot more consistent and higher amounts. Why this is important is that you can imagine that if you are not picking up much human material, which is reflected when you don't have much human RNase P, if you're not picking up much material, this could obviously also influence how much virus RNA you're detecting and whether you are collecting sufficient amounts of that as well. This was actually evident over a year ago. This is a paper from March 19th, 2020, so also very early in NEGM, where you can see viral loads from swabs collected from the nasal or throat swabs in patients. And you can see that individuals may have been positive one day, but then negative the next, positive the next day, negative the next, positive, and so on. And again, this, I don't believe, many others don't know, that this isn't likely a reflection on viral load and viral load circulating so much, but rather the possibility that with swabs, especially with under pressure healthcare workers, people who are rushed, individuals who are sick and not enjoying having swabs collected every couple of days, that this just leads to this variability with swabs, is that you can maybe just not pick up enough material, which can influence what you see in result to that. And this is why we like the reliability of a saliva sample, that you can see what you have in there and that you know that you have enough material that you can actually test from. A good saliva sample, however, is critical for a good test. So saliva tests must be designed specifically for saliva. Saliva is the collection of all oral fluid, but it is not sputum and it is not mucus. We do not want people sniffing beforehand or coughing anything up. That also, increases the risk for respiratory droplets. And if not properly collected, it can be difficult to work with. Saliva is not a traditional diagnostic sample type. This also means that methods that work for swabs don't necessarily work for saliva, so that you can't just take a method that you know works in your lab for a swab and expect it to work on other sample types. If you think about a saliva sample, it can be quite different to what a swab in VTM is like. We recently looked at 54 RT-qPCR based saliva versus swab comparison studies that were published in 2020, and we actually found that 69% of those had saliva to have similar or even greater sensitivity as compared to swabs, and that saliva did detect an additional 10% of positive cases where MP swabs were negative. So this again really highlights that there are many discrepancies in comparison studies out there, but is likely due to either poor sample collection or methods that are being applied, and that we need to really be looking at the collection methods, processing methods that are leading to good results and sort of focus on replicating those in other settings. So to collect a good saliva sample, it is really important that people are patient. You can think about your favorite food, and not to sniff, not to cough, and not to spit. You can think about, if you use that word spit, that already that image of maybe aerosols sort of going out, things going all over the place, a lot of the spray. This is where the sort of term drool comes in, to have that more slow, controlled collection of saliva. We studied these various different devices, so just a very simple pipette tip, saliva collection aid or a short straw, funnels, and even a bulb transfer pipette to see these could also further aid saliva collection. We tested these out in 30 different study participants, and they had to test each of these 4 devices in an unobserved or an unsupervised collection manner. So we switched off all cameras or microphones. We could see them, they couldn't see us, and we just had to sort of assess how well they took their samples, and they also had to tell us how well they assessed it. So this is just a snippet of the participant feedback we received. But overall, despite the device, the study participants felt comfortable. They felt as though they didn't need help while collecting their sample based on good quality instructions. They knew what to do, and that they mostly felt as though that they were confident in collecting that sample properly. When these samples were received at the lab, they were all of sufficient volume, they were all easy to pipette, they were all true saliva, and they were free from food particles and not discolored. And importantly, they were mostly in the range of what we would expect for the human RNA-seq quality control. Based on this, we have received EUA updates for both unsupervised collection as well as at-home collection, which I know they might sound similar, but there are very particular differences in the 2 of these that we can go into if needed. Importantly, and I think what hopefully we've portrayed so far, is this is a flexible, adaptable, and widely applicable protocol. We have gone from this very limited number of instrumentation and PCR kits at the start, and we have expanded this rapidly into a greater number of PCR instruments, and importantly, a number of these are both 96 and 384 well formats. Instrumentation is where we really prioritized our bridging studies to begin with. And I think understandably there are many PCR kits out there on the market. We expanded to the Luna 4X just based on its use in 384 well formats. We also recently obviously added the QuantiBio UltraPlex one-step tough mix. So we really had to prioritize what we're adding and what we're spending our time on doing these bridging studies. But we had heard of the benefits of the tough mix for direct extraction, and tough mix, knowing that saliva is a more difficult to process saliva sample. This is something why we looked into it. Also because of the fact that it had been incorporated by the CDC, we felt that if this was also prioritized by the CDC, that this was also an important addition for ourselves to make. We have also, I mentioned that we started at the 96 well format. We have a very standard universal protocol going forward. We have also expanded this to the 384 well format, where we've basically essentially just halved our reaction mixes. We try to keep everything as uniform as possible, just so that, say, for example, if you had to sub out the NEB Luna 4X for the Biorad Reliance, you could use the same reaction mix SOP without having to worry about changing quantities, for example. At each of these steps, we continue to measure our LOD across the different reagents, across the different platforms. So these are just the results for when we added the QuantiBio UltraPlex Tough Mix. You can see that we did get down to that lower 3 copies per microliter, and at the 6 copies per microliter for the NEB Luna 4X. This is also just an example of the many different PCR instrumentation bridging studies that we have done. And again, just a variety of instruments, a variety of PCR kits, getting down to around that 3 copies per microliter, some slightly higher at 6, some slightly lower, but indeed maintaining this level of sensitivity across reagents and instruments. The protocol has evolved further. We had been talking to a lot of labs who, when samples were going to be arriving in the labs, they wanted to either heat them for, some labs were already looking at doing 95 degrees for 30 minutes. We also like the idea of 65 for 15 minutes, just so that you have less of a burn or melt risk. And so we investigated how that heat pre-treatment would work prior to our normal workflow, which is workflow 2. And then while we're doing this anyway, this heat pre-treatment, we decided to test what would happen if you put this straight into PCR. So again, this was done to promote safer handling of the samples. And we've also heard that doing these heat pre-treatment steps, it improves the viscosity of the saliva. So it actually makes the samples easier to pipette at these later steps. So again, looking at our LODs for these different workflows, we again maintain that level of sensitivity. So around that 3 copies or 6 copies per microliter, whether you're following the SalivaDirect protocol, which is down the bottom here, or even going straight into PCR testing. So overall, while saliva can be a reliable and sensitive sample type for SARS-CoV-2 detection, again, it's a collection of all oral fluids. So you can think about if you've got a bit of nasal drip or your mucociliary clearance coming up from your lungs, that you're sort of collecting, and also it's being produced by your salivary glands, that you're just collecting this quite the mix of oral fluid that collects in the mouth. Importantly, healthcare workers are not required to collect saliva specimens. This reduces the risk of transmission. It can decrease the waiting time for specimen collection so that results are available sooner. And it's also practical for efficiently testing a large number of individuals. This makes it very well suited for frequent or repeat testing, and that these benefits could prove even greater in low resource settings. We are seeing that COVID-19 outbreaks are continuing, and they are disproportionately impacting vulnerable societies. Inexpensive, simple, and scalable testing methods can greatly help in this. We do also need to be thinking about a shift in our thinking of traditional diagnostic testing to screening tests and ongoing surveillance testing to help to catch outbreaks a lot earlier on and prevent chains of transmission. So the key points in closing about SalivaDirect: it is an open source initiative for COVID testing. It is a protocol. It is not a test kit. Importantly, we have no commercialization. We make no profit. We have, I think, nicely introduced at the start, we don't have any financial involvement with any of the companies or reagents or anything at all on our protocol. We do not have licensing fees. We do not have agreement fees. All we're trying to do is help to authorize other CLIA certified labs to run our protocol. Any of these EUA updates, whenever we make them, they are immediately available to all authorized labs. We really did this just to reduce testing costs. We did it to reduce the implementation time to use saliva. We do all the upfront validation work for the labs, just so that we can try to help the number of tests that are available in the community. So thanks for having me. Thanks everyone for joining.